Good morning, everybody. I'm Andy Oxman. I'm a researcher at the Norwegian Knowledge Center for the Health Services. And for this session, we're going to have a relatively brief discussion of decisions about health systems and public health decisions that are made for populations. So these are decisions that have to be made by a small group of people on behalf of a larger population. So they're different from clinical decisions or from coverage decisions in a number of ways, in that people often cannot make individual choices. So if you are making a decision about whether or not to have a stroke unit, each individual can't decide that. Somebody has to decide whether you're going to have a stroke unit in a hospital or provide collaborative care for depression, or whether you're going to ban smoking in pubs, or so changes in health systems are public health decisions that then limit or affect the choices that people can make after that. So everybody, or nearly everybody now, I'm going to assume has encountered the evidence to decision frameworks. And in this session, you're going to hear about two examples of guidelines. So these are recommendations for policymakers or managers to make decisions that are health system or public health decision. And so our first speaker, Metin Gomezoglu, is trained as an obstetrician and gynecologist in Turkey before he went to South Africa, where he worked as an obstetrician, did research, following which he went to the perinatal epidemiology unit in Oxford and subsequently to the UK Cochrane Center before moving to WHO about 15 years ago, where he's now the coordinator for perinatal care in the Department for Maternal Care and Research. He's also an editor. He's been an author of about 30 Cochrane reviews. He's editor in 2 Cochrane review groups, Pregnancy and Childbirth and Fertility. And he's also the coordinator for the WHO Reproductive Health Library. And Metin is going to speak to you about an example of health systems recommendations that he developed for WHO. Metin?
Good morning. I'm going to talk briefly about our experience with one health systems guideline that we published, and I apologize if some of you saw some of the slides before. This is a guideline where we worked from WHO with huge help from the Norwegian Knowledge Center and from Claire, Sarah, Jenny, Simon, among others. So now, as you know, in WHO, guideline development is one of our main forms of communication with our regional offices, country offices, and policymakers in member states. So we do a lot of guidelines, and many WHO departments do guidelines. These are some of the guidelines that we have been publishing recently, following the handbook for guideline development that Holger Schünemann contributed to heavily. And most of our guidelines use GREAT framework. These are all using GREAT methodology except for one, but none has used the DECIDE framework. And I think the big advantage of using GREAT and DECIDE is where we can make the judgments explicit, as you all know. And I think with GREAT, because of the emphasis on quality of evidence and randomized trials, non-randomized trials, upgrading, downgrading, I think the judgment part got a little bit pushed back. And in DECIDE, I think this is one of the big chances that we have where we can actually address those issues in a more explicit way. This is the guideline that Andy was referring to. It's titled Optimizing Health Worker Roles to Improve Access to Key Maternal and Newborn Health Interventions Through Task Shifting. So we had all these effective practices for maternal and newborn health, including contraception. And then we had 8 cadres of health workers for which we made recommendations who can deliver or who's recommended to deliver which practices. So it was a big guideline with a lot of recommendations. Our guideline development process in WHO is fairly standard. We start with identifying the questions and then critical and important outcomes. We start with systematic reviews and assess the quality, and then we come to the panel. And the panel makes the recommendations, and as with any other guideline. And this is, for us, the most challenging part. And then we go with dissemination, implementation, and so on. And what tends to happen in our guidelines, and I don't know if others have similar experiences, is we have good sort of structured processes for looking at benefits and harms, but when the panel has a discussion, all these issues around acceptability, feasibility, equity, implementation considerations get sort of lumped together, and then a certain recommendation is made. And I think that is the beauty of the DECIDE framework, where we have this chance to tease out these different domains and make sure where we put our emphasis and how we make our judgments. Now, for this guideline, what we did was, because these recommendations that we were making were so complex and it related to human resources, organization of care, and so on, we felt that we needed to address acceptability and feasibility in a bit more systematic way. And we decided to use upfront qualitative research synthesis from studies that looked at barriers and facilitators to access to care. And we also did selected reviews of program implementation reports. Now, I don't know of any other WHO guideline that systematically used qualitative synthesis in the guideline process, and whether any of them used program reviews in their recommendations. It clearly has implications in terms of time and resources and skills, but we had a very positive experience with that. The synthesis that we did through qualitative reviews gave us a lot of information on acceptability and feasibility, and that allowed us to make some recommendations even where there was no direct evidence for a particular recommendation and particular cadre. But they also told us a lot, especially the program reviews, told us a lot about implementation considerations, because there we could capture how programs have failed or succeeded, and it was possible to get some of that information from those. We did not use these for effectiveness evidence, but for the populating the other components of the frameworks. What we see often in our guidelines and guideline panels is we invite people with country experience, programmatic experience, and there is an immediate allergic reaction to going only through randomized trials. And they tend to say, you know, but these programs have been running for years and so on. So putting this systematically into the process, I think, allowed us to communicate better with the panel members. And the qualitative data for specific questions, I think, gave the impression that we are not sort of rigid in the type of evidence that we are looking. Another problem that we often have is our panels, as your panels are too probably, are full of experts, and they tend to highlight their experiences and anecdotes, and it allowed us to confront those anecdotes because we had actually done systematic reviews of how people were experiencing those practices or those working with those cadres. So I think it helped us in some real sort of objective ways, but also with the psychology of the panel as well. We are disseminating these through our policy briefs using the support summary formats, and because there are a lot of, it's very rich, there are a lot of recommendations for either different components of maternal newborn health and also about different cadres like lay health workers and auxiliary nurse midwives. And we are starting a new guideline. We have started working on a new guideline on antenatal care. And this is an area where WHO conducted a large trial that was published in 2001 that showed non-inferiority of an antenatal care model with fewer visits. And that kind of became a easily implementable model, although WHO never issued proper recommendations on that. So now we are 10 years after that, we are looking at antenatal care, and we started looking at the frequency and number of visits, but then it immediately became clear that antenatal care is so complex and that we can't just look at how many times people come and so on. So this is the outline that we are working from, and we are going to review individual practices like iron supplementation, calcium supplementation, counseling, and so on, for which we are going to rely on Cochrane pregnancy and childbirth reviews. We are going to do reviews of antenatal tests through systematic reviews. We'll look at health systems and community-level interventions, such as who's delivering the care, group versus individual care, through probably through Cochrane EPOC reviews. And we want to do a bigger sort of synthesis of country programs where countries have implemented the 4-visit model, which is also known as the focused antenatal care in some countries, and whether they have successful experiences or not. Our experience from the previous guideline of task shifting is these program reviews don't really give us any evidence and information on health outcomes or health impact, but they tell us a lot about implementability and the bottlenecks when people set out to implement these programs. For that, we will probably follow SURE frameworks. And as you have been exposed to during this meeting and the Barcelona meeting, we intend to do systematic reviews of qualitative synthesis, qualitative research using the CIRCLE tool about barriers and facilitators to accessing care. And one issue that is still a question mark is the use of modeling that we haven't decided yet whether we can or we should use in the guideline. That relates to the spacing and frequency of antenatal care visits and how we can give better advice to countries on tailoring the recommendations according to their settings. So in our experience, if we ask the question whether having used DECIDE, is it worth it? I think it helps a lot with health systems type recommendations because it allowed us to populate the other domains in a very visible way. As I mentioned, it helps in managing the panel, but only if you populate the domains and the frameworks before coming to your panel. I think there's a huge amount of work we need to do before actually coming to the panel. And the decisions about what kind of reviews we are going to needs to be made right at the beginning because that has time implications. I added this interactive evidence to decision bullet this morning after seeing it for the first time, and I think that is going to be a major facilitator in using the panels, using the framework in advance of the panel meetings and communicating with our panel members. So that's our experience and take on it, and for the most part it has been a positive, although time-consuming experience. Thank you very much for your attention.
We have time for a couple of questions or comments.
My name's Paul Garner from the Liverpool School of Tropical Medicine. Thanks, Metin. That was really interesting and fascinating. WHO is making global recommendations, although usually focused on middle and low-income countries. Can you tell us about, acceptability and feasibility are often national or local considerations, whereas evidence of effectiveness is perhaps more generalizable. So how did the reviews feed into global guidelines when often they're local or national decisions?
I'm sure Claire can talk to this better than me, but I think for some questions, the evidence was so compelling. When you look at lay health worker programs, the barriers, and I think there was like more than 60 studies that contributed to that review, which actually now is matched as a Cochrane review with the effectiveness review. I think the quality evidence was quite coherent, and it was really applicable and generalizable through different settings. For some, it wasn't, but I think it depends on the body of evidence.
Thank you very much. I have one question in regards to your last slide. You made one comment where you said populating the evidence to decision frameworks during a panel meeting is probably not a good idea, and I wonder if that requires clarification. The experience has been that disenfranchising panels from the judgments that are made about the various criteria in the evidence to decision framework is not a good idea. That is, presenting them with judgments before it actually gets to the panel meeting means that they feel less involved. It looks like there's less buy-in. So are you suggesting to prepare everything, including the judgments, that a technical team does that? Because I think that is really different from, first of all, how we've applied it. And I think that really will lead to barriers in terms of buy-in from the panel. So what I'm referring to for everybody is the judgment, the second column, where you, for instance, decide about the magnitude of the benefit and the balance of the benefits and the harm.
Well, we prepare everything beforehand, including the recommendations. So, and we make it very clear to the panels that everything is changeable. Nothing is cast in stone. Everything is questionable. But if you don't do that, in our opinion, I think whether the panel would feel alienated or it would reduce the buy-in, I don't know. I think that depends on your relationship with the panel as well. And I think if they get the impression that these are done in an honest, transparent way and that they can still contribute, I think that shouldn't be a problem. Depends on the panel, I suppose. If you try to populate during the panel meeting, when you have so many recommendations, I think you run the same risk as the louder or the more experienced and the most senior driving how these are populated, and it may not be based on the evidence. So I think, in our opinion, populating them beforehand helped us.
Thank you, Metin. That was an absolutely brilliant presentation, and I feel really privileged to be part of the process of the review development and all the methodological innovation. So you're both a user of evidence in WHO as well as the producer of evidence. And one of the sort of seminal things that happened in Cochrane was that the lay health worker review and the nurse-doctor substitution reviews were registered by EPOC as Cochrane reviews. So we can thank Andy Oxman and others for helping facilitate that process. And you've clearly given a very clear steer that it was of great value. The maternal child health reviews, however, the maternal child health review group don't want to register any qualitative titles within Cochrane. And as a user of evidence, is there anything that you can sort of help us with in terms of trying to change hearts and minds about the value of qualitative evidence and whether Cochrane should see it as a vital evidence resource for guideline development?
Yeah. I think the problem the Cochrane Pregnancy and Childbirth Group faces is more of a practical and a resource issue, because they have such a massive load of effectiveness reviews that they are struggling to keep up with. They can't, or they don't feel that they can put aside or create new mechanisms for reviews of other questions, and that applies to diagnostic reviews as well. It clearly requires a different skill set. So, Cochrane Pregnancy and Childbirth Group editorial composition is fairly clinical, intervention-oriented, trial-oriented people. So I think that's a bigger discussion, how groups can expand, and David is here, maybe he can respond to that, how they can actually address these thematic issues, which I think the EPOC group is not very keen to jump into, and how it can be made possible, maybe through qualitative review group. I don't know, but I think it's mainly a resource issue.
Thank you. So we may come back to that discussion in the panel discussion in the last plenary session. Now I'd like to introduce the next two speakers, who both come from the National Public Health Agency in Sweden. Karin Gulbrandsen has a PhD in public health, and she's also an affiliated researcher at the Karolinska Institute. And her interest, she's very interested in implementation of public health interventions, both at the national, regional, and local levels. And Nils Stenström also works at the Public Health Agency. He's affiliated with the Mid-Sweden University as a researcher. His interest is in grading evidence and recommendations, and he's particularly interested in alcohol and drug abuse prevention. He's currently working on a review looking at those problems. He's also a member of the GRADE working group. So, Karin, are you, Nils?
So good morning, everybody, and thank you for inviting us to speak at this conference. This presentation is about a study we made in connection with the Government Commission on recommendations in the field of public health in Sweden. So I will begin by giving you a brief background. Authorities in healthcare, as well as public health, is expected to provide to provide practitioners and policymakers guidance on best practice in their respective fields. However, within the field of public health in Sweden, there are no comprehensive systems for recommendations of effective methods. Claims from government agencies and other organizations about the scientific strengths of specific interventions have been based on different grading systems, which in some cases has led to conflicting assessments and in turn frustration, inability to act, and a lack of confidence among practitioners and policymakers. So in an attempt to rectify this, the Public Health Agency received a government assignment in 2012 to investigate and propose how a transparent systems for recommendations in the field of public health could be designed. The assignment included to assess the scientific quality of a public health intervention using GRADE, to investigate the experience of recommendations assessment in other countries, and to assess whether any of these systems could be implemented or directly used or after adaptations in Swedish conditions. So according to the assignment directives, recommendations shall include several important aspects when deciding, including potential side effects, acceptability, ethical considerations, and resource demands. In our case, a number of aspects deemed central to recommendations in Sweden were selected. In addition, the recommendation system also should be able to provide guidance even when the scientific evidence is weak, and be able to identify knowledge gaps. Within the DECIDE project, as I guess most of you or all know by now, members of GRADE Working Group has developed an integrated system for recommendations in public health that meets most of these aspects. Since using GRADE was a part of our government mandate, it was natural for us to consider whether to use the DECIDE evidence recommendations framework to see if it was applicable even for Swedish conditions. So the aim of our study was to investigate if the DECIDE evidence recommendations framework were applicable in the public health field in Sweden. In this study, we tried to follow all steps in the GRADE process. As we, at the time, were quite inexperienced GRADE users, we turned to our Nordic colleagues at the Norwegian Knowledge Center for guidance, and we received a lot of support. So now Karin will briefly describe each step in the process related to our study.
Yes, how did we do to find out if DECIDE was applicable to the public health field in Sweden? First, we formulated a PICO question. Should behavioral and cognitive behavioral group-based parenting programs be used in children aged 3 to 12 years with early conduct problems? This topic was chosen since parenting training programs have been highly focused in Sweden during the last decade. Second, we did the literature search. We had to be pragmatic here since the time for the government assignment was very limited. We identified a Cochrane review about parenting training programs published in 2012. In this review, meta-analysis showed that group-based parenting training programs reduce conduct problems among children. In the third step, the quality of evidence was rated by using GRADE and GRADE Pro, and the quality of evidence was considered moderate. Now, with the evidence in place, it was time to test DECIDE. The DECIDE framework was presented and discussed in 4 semi-structured group interviews, in a stakeholder test panel, and in meetings with governmental organizations. The informants were stakeholders from local, regional, and national level in the public health field in Sweden, and from different parts of the country. In each meeting and interview, the DECIDE form and the DECIDE panel procedure were described and discussed. The participants were asked to comment on each question in the form and on the panel procedure from a public health perspective. The purpose with these activities was to get feedback on the different part of the DECIDE framework from actors relevant for public health recommendations in Sweden. Finally, the results from the previous steps were used in an authentic DECIDE panel with the purpose to make a real-world recommendation regarding parent training programs in Sweden. And what did we find? The main finding of this study is that the readiness to use the DECIDE framework seemed to be present in the public health field in Sweden. In general, the informants were positive to DECIDE on the whole, although some adaptations to the DECIDE form were suggested. 2 criteria were suggested to be added to the DECIDE form: individual autonomy and method sustainability. The following questions were formulated and added to the Swedish version of the DECIDE form. Does the option take into account the individual's right to self-determination, and is the option sustainable in the long term? Niels will come back to possible explanations to this result. Finally, a recommendation was agreed on by the panel. The panel ticked the boxes: desirable consequences clearly outweigh undesirable consequences in most settings, and we recommend the option under certain conditions. The certain conditions were that the intervention must be adapted to different target groups, the quality of the implementation process must be secured, sufficient resources for supervising and quality development must be reserved, and the intervention must be evaluated. Yes.
So, based on our studies, Karin pointed out there seems to exist a readiness to use DECIDE within the public field in Sweden. Almost all informants believe recommendations are needed for guidance in practical public health work. And just to present results from systematic reviews, it's not enough for guidance, was a common comment. As Karin just said, 2 modifications were made to the original DECIDE form to make it even more suitable for in the Swedish context. Regarding the first added criteria, individual autonomy, the comments from the informants indicate that this is an important value in Sweden. In the World Values Service culture map of the world, where each country is positioned on a continuum according to rational versus survival, traditional versus rational values and survival versus self-expression values, Sweden shows the highest score on both rational and self-expression values. Thus, individual freedom and self-expression are highly valued in Sweden, which could explain the emphasis that is put on those criteria, on the criteria individual autonomy by the informants in our study. The second added criteria, method sustainability, was highlighted based on the informant's experiences of short-term projects with diminishing method sustainability in the long run. In public health, as well as in other fields, new interventions are often funded as time-limited projects with an intention that they will be established after finalizing of the project. Features of sustainability are, however, weakly described in the literature. Thus, that the criteria regarding sustainability was lifted by the informants seems to be highly relevant. In the original DECIDE form, acceptability and feasibility are criteria that might comprise individual autonomy and method sustainability. However, the existing criteria were obviously assessed not to capture individual autonomy and method sustainability to a sufficient extent by the informants in our study.
How is the Agency of Public Health in Sweden dealing with GRADE and DECIDE now and ahead? We are currently supporting 3 government assignments in which GRADE and DECIDE are applied. In one of these assignments, a DECIDE panel will be arranged in mid-June. In the others, we don't know yet. Further, we are engaged in a local decide project regarding cannabis prevention in a municipality in the north of Sweden. We do also receive a number of questions about grade and decide. Thus, there seems to be an increasing interest about this in the public health field in Sweden. Thank you.
Questions or comments?
Hello, Frode Forland from the Norwegian Public Health Institute. Thank you, Sweden, for showing us this nice examples of how you can work out the DECIDE system with the help from the Norwegian Knowledge Center for Health. And I think this is a good example of trying to use it in practical terms, which is what we need. And just to inform you, there are several questions, at least as I think, that are still not explored in the field of using this system for public health questions. And I've been working mostly in infectious diseases lately, about how the spread of diseases are in an outbreak setting, how we can evaluate modeling studies, what are the causes of diseases, and what are the impacts of outbreaks of diseases, for instance, and on different public health interventions. And I think this is also where we need to really expand this field. And just to inform the public here, there is also a group originating from the European Center for Disease Prevention and Control, based at the Robert Koch Institute in Germany, who's working on some of those issues, called the PRECEPT. And they are a number of members of this advisory panel are here, from DECIDE and from NICE, and I'm also included from the Norwegian Public Health Institute. And I think we should get in closer touch with you and also with the rest of the work which is going on in the DECIDE framework. Thank you.
As we are very, we believe that we have got a lot of support from both from GRADE Working Group and from the Knowledge Center in Oslo. And we are very thankful for that. And we believe that a strength in this work has been the possibility for international cooperations. We've done a couple of testings now, but we believe that there is really a lot of work that is ahead of us. In Sweden, we lack a sort of infrastructure for recommendations. So even if we are able to make specific recommendations, we need to have a system for disseminations of recommendations.
Well, thank you to all three of our speakers for brilliant presentations and for keeping to time. And to all of you, you've now got 5 minutes to get to the workshop. Thank you. I'm going to pose a series of 4 questions about where do we go from here. So it's a nice follow-up to the presentation we just had. And I'll first give the panel member a chance to answer, but I'm posing the questions to you as well, so that you'll have a chance to both comment on the question or what panel members have said, or to ask questions. All right? So I could take the rest of the time introducing the panel. It's an illustrious panel, and we're very happy to have them all here. So I'll start with Jocko Burgers, who many of you will know. He's a general practitioner, and he's the head of the Department of Guideline Development and Research at the Dutch College of General Practitioners. He's been in the guideline business for a long time now. He's helped to develop almost 100 different guidelines. He's a researcher at the IQ Healthcare at Rebond University at the Nijmegen Medical Center also. He's authored over 100 peer-reviewed journal articles on guideline development and effectiveness, including Agree and Adapt, which we've heard about, and he was a board trustee of the Guidelines International Network, GIN, from 2003 to 2011, and the chair from 2007 to 8. Roberta James, who we've heard from, who I guess is one of our hostesses here. is the program lead at the Scottish Intercollegiate Guidelines Network. She has responsibility for the currency, validity, and timely development, dissemination of signed guidelines. She has 10 years' experience producing evidence-based guidelines at SIGN, and she's interested in presenting recommendation in ways that fit the needs of professional and public audiences. Roberta is part also of the Guideline Implementability Research and Application Network, GIRANET, which I'm not sure we've heard much about yet, which seeks to integrate guideline development and implementation by identifying, developing, and evaluating and sharing guideline implementability tools. And she collaborated with the Health Protection Scotland to introduce methods to develop evidence-based guidelines for health protection in Scotland, and has a strong working relationship between the two organizations and an ongoing interest in using evidence that falls out with the recognized hierarchy in developing guidelines. Steve Pilling. So I'm hopping over Dave. I'll come back. Well, I'll take David. Many of you will know he's the editor-in-chief of the Cochrane Library since 2009. Before that, he was the editorial director of the BMJ Evidence Center, which is the division of the BMJ group that produces clinical evidence and its counterpart for the public, Best Treatments, and BMJ Point of Care and Best Practice. Dave worked as a general practitioner in an urban practice in South London for 15 years before moving to the BMJ. And during that time, he also undertook roles in continuing professional development for primary care professionals and was a clinical governance lead for the primary care group. And now back to Steve Pilling as the director of the National Collaborating Center for Mental Health, which produces the NICE mental health guidelines. He's also the director of the Center for Outcomes and Effectiveness at University College in London. His research interests include health services research, including trials of complex interventions such as crisis intervention teams and implementation studies of health service policies, psychological treatment, particular treatments for depression, and competencies required to deliver effective interventions for all psychological treatments and disorders. He works on systematic reviews in mental health and their use in clinical guidelines and clinical guideline development and implementation in mental health. So we've got an excellent panel. And the 4 questions that we're going to address are looking at where we should go from here from different perspectives. Of guideline developers, then look at it from the perspective of policymakers, and lastly, what do we need from researchers, research funders, and publishers, so other players in this area. So I'll start out with the first question is, what are the main challenges and opportunities for guideline developers, health technology assessment agencies, and producers of systematic reviews, and what should be done to address those challenges or to take advantage of those opportunities? So, Steve, we'll start with you, and then...
We don't want to address each question. We'll
do one question at a time.
So, microphone, thank you very much for the reminder. I have a voice that usually carries and gets me into a lot of trouble, so I've learned over the years to switch microphones off. But what are the challenges? I should just say that I'm presenting this very much from a NICE perspective, so I'd be grateful if people could bear that in mind. But these are a number of our challenges and preoccupations, and many of them have already been referred to. But number one for me, we had 4 questions. I decided to each, 4 points to each, is updating existing guidance. It is for NICE a major problem, and I think it reflects the fact that our systems for actually developing them are in fact flawed, and that we need to actually begin to shift the way we develop them so that the process of updating becomes much easier. We've heard a lot about efficiency and effectiveness in production, and a lot that's very encouraging and very interesting over the last few days about the technologies that allow us to better translate the data that we've acquired into effective recommendations. I think a real challenge for us is getting better digital approaches to effective searching, sifting, and the assessment of data. I think there's a lot that could come in greater efficiency about the ways we do that, and there are a number of people around already doing that. Very much agree with Sonia about collaboration, but I also think that maybe that collaboration also needs to take a step back, and it's the sharing of basic data sets, the building up of data repositories, of trials, of studies, of systematic reviews that we need, I think, to be working on. And then a final challenge for us, I think, is what, again, Sonia talked about, was a lot of sharing between systems that are already really very well developed. Now, this may well be a preoccupation of David's as well, but I think we need to be looking about what can we do for low and middle income countries to make available the products that we spent a lot of time and money developing and that they need assistance with. So there'd be 4 challenges for me.
I'll try not to repeat the same things. It seems to me that probably all of us share the challenge of getting our work really into practice and policy. So we, as systematic review producers, Cochrane, we are definitely recognise that as a very major issue. You know, and in terms of justifying the expenditure, key part of that justification. It's fine to produce the reviews, but they have to influence people, otherwise, you know, they were in trouble. And I suppose for Cochrane, there's an obvious challenge that when in 1993 the 70 or so people met in Oxford, they were pretty much the only international systematic review producer, and now we're very much not the only international systematic review producer, and we're in a very competitive world all of a sudden. But my 3 or 4 specific, I guess, challenges for review producers start with the balancing the sort of triad of cost, quality, and timeliness. I'm told probably about once a week that it takes too long to conduct and report a Cochrane systematic review. And I smile and sort of agree. But actually, reviews are getting harder, they're getting more complex, they're getting more sophisticated, they're looking at different and more complex interventions, and looking at different types of reviews and enhancements of reviews. And actually, that's a very large part of the reason they're getting longer. So at the time that we want to reduce the time it takes to conduct a review, it's getting longer for understandable reasons. So we were talking in our workshop earlier about the need perhaps for a methodology of methodologies. You know, as people will know, we recently published a review of clinical study reports, which was sort of 4 years of some very obsessive people's time. And hope you won't take that as anything but a compliment. And, you know, is it feasible, therefore, for every systematic review that ever gets produced by Cochrane from now on to be a review of clinical study reports? I think we need a methodology of thinking about what level of review is appropriate. There may be some reviews that can be perfectly adequately done by a rapid review of how we define that, and you know, that's clearly a need for us. Challenge 2 is the challenge of reporting bias, which takes us back to Tamiflu and the problem of clinical trial availability and transparency. You know, if the selling point of a systematic review is that it reviews all the relevant high-quality research, and we know that some of it's hiding else out of sight, and particularly if that data that's hiding is skewed in a particular direction, then clearly that undermines the argument to a certain degree. Thirdly, I think there are still, I think it's clear that from guidelines, world systematic reviews are common currency, but every so often I talk to my ex-colleagues of health professionals, and you know, it's very clear to me that the sort of culture of systematic reviews hasn't yet totally permeated their world. It might be a local problem in South London, but I'm not so sure. So, you know, the perception that if you want to know an answer to a clinical question, you look at systematic review isn't necessarily yet ubiquitous, and I think that that's also a problem, and there's perceptions around complexity and difficult to understand and perhaps difficult to put into practice. My last, just picking up on Steve's point, is the major problem for Cochrane and probably other systematic reviewers around updating. And I think we maybe do need some new methodologies to do that. At the moment, people tell me when they update a review, it's usually about the same level of difficulty as conducting a new one because the methodology has been upgraded in the meantime. And that's a real challenge, and it cuts to the core of our mission, which is to keep a database updated. We publish a lot of updated reviews, but we still fall behind year on year. So that's my lot.
Great.
Well, I would reiterate from the sign point of view the challenge of keeping guidelines up to date, so I don't think it's any different. And I would just completely agree with the comments that Stephen made about keeping things up to date and the difficulties of updating something that you want to keep up to date. I think for us as quite a small organisation, one of the challenges for us is also keeping up with the methodology. We are quite a small organisation. We use a lot of clinician input, trying to get clinician healthcare professional input. That's a huge challenge for us. And I think it's just the feasibility of what we're able to do in our small setting and in the relatively small pool of healthcare professionals that we can pull on to keep going with the job in hand of producing guidelines whilst trying to keep up with the methodology. And we've heard of some really great stuff these few days, but the prospect of even starting to implement some of it is really quite daunting when we've got so much to do in such a back catalogue to keep updated. I think as well from the point of view of actual guidelines, I think Bruce Guthrie started off the conference with a really good talk about multimorbidity in the ageing population and how we can produce guidelines that are relevant for our population, and the fact that sometimes we're looking at an evidence base of patients in trials that doesn't match our patient population, and how we can make recommendations that are relevant to our patient population. And I think that the last thing pertinent to guidelines as well is just getting people to use them, implementing them, knowing that, and then finding out by some means if they're having any impact, and if they're not having an impact, what we can do to make them have more impact. And I think the solution for me is going back to everything that Sonia said, is just working together, working collaboratively on the evidence base, of working together so that we're not having to bear the burden when we're small organisations, but we can work together to get a common solution across our near neighbours and our faraway neighbours as well.
Okay, before answering the question, I would like to thank Robin and Andy for this fantastic conference. It's so well organized, and I also like the timing of the conference, that you present the tools, very sophisticated tools with a lot of work, that you discussed it with the participants and are open for feedback, and I'm looking much forward to the final tools and final presentations on that. So thank you so much. It's a great conference. What has been said before, we did share the questions, but not the answers. So, if we talk about duplication, so the answers will duplicate. But part of the question was also how to address the challenges. So I try to focus on that. So my first point was also the updating of the guidelines, how to do that. And we mind the publication of Paul Schickel in the JAMA recently, and he said you do not need to update the whole guideline. You should focus on only those key new developments and try to develop pragmatic solutions, not only doing the literature search very complete, but try to combine it with expert opinion. And that's an approach we also do at the Dutch College of General Practitioners. We try to do it as partial, similar as at SIGN and NICE. I like that approach. The second point, echoing others and Sonia, collaborate. So it's very important developing organizations know what they are doing. Similar as Sign and NICE, they have a large table of all the guidelines that has been produced, but also in the right column which guidelines are under review. And that should be produced so that you know what are the topics of interest. Some point about the methods. So I'm very happy that GRADE is now overall worldwide accepted and used, but it's still difficult for some organizations to use such sophisticated tools. And we, at this conference, a lot of new tools has been presented, and it's as an advanced guideline developer, I'm really happy to have that, but I'm also a bit concerned about guideline developers who are starting, and they need a lot of training and instruction. So I would also recommend to start that, as GRADE was also promoted with a lot of training and education, to also set up training courses for the other tools that has been set up, and also to allow some flexible use. So you can use GRADE full-blown with all the specific tables and all the software all around, but you can also choose a part of GRADE for your process and start building up that. So it's a step-up process. A third point is the translation of guidelines and guideline information to patients and consumers. I think there's a lot to win on that. Most often it's chronically, it's after it. So you have the guideline and then you have the patient information material, but it should run in parallel. We at the Dutch College of General Practitioners, we have two departments of guideline development and guideline implementation. And implementation is also developing patient information material, and it is as large as the development department. So a lot of focus on implementation and patient information. And when the guideline is published, the patient information materials is also ready. And we produced a press release about the guidelines, which includes information on the website for patients. And my final point is, well, the implementation, to let the guidelines really do their work. So it should really work. And you need to evaluate that. You need to have tools and indicators to monitor the use of the guidelines, and not only adherence, but also the use, whether the user likes the guideline. As a general practitioner, I use my guidelines, but every day I also deviate from my guidelines because I have an individual patient with multi-morbidity, but I still use the guideline. I like that. So I think we also need qualitative studies to evaluate the use.
Excellent. Comments, questions? Other thoughts? They've said it all. I would like to, yeah, Sean?
Okay, I'm Sean Treweek from Aberdeen. Thanks for those comments, very thought-provoking. For my last, I think it was the last workshop I was at, or maybe it was a coffee time discussion, but it was about small producers such as Sign. I think it was actually linked directly to Sign, who do not have a technical team. So I think it was your comment, Jaco, about... And I'm wondering if there are... something like NICE, there's a huge machine behind the NICE process. There's a big technical team. They have the resources to implement really rigorous processes. For smaller guideline producers, it might be a professional association. If they want to use something like GRADE and some of the tools that we've been talking about, what would your thoughts be to those organizations if they say, well, we can't have a technical team? What would be the good enough approach for those guideline producers?
I think I have two thoughts about it. One of which is I do think that an awful lot of the time that we spend producing NICE guidelines goes into that initial process of identifying and assessing the quality of the evidence. And I think the next technical challenge, as I was saying earlier, is to make that much more efficient. And I think that can reduce technical time demand. It's not going to reduce guideline development group panel time, but it is. And the other one, of course, is which relates to the way in which we develop guidelines, and I'm not sure they're quite fit for this purpose. But as we've seen in examples talked about in a number of the workshops I've been in, it's about adopting and adapting guidelines that have been developed elsewhere. And again, I think our methods for that are perhaps not where they should be. But I think that's a way in which, if we develop them slightly differently, although perhaps not much, then that would be another way in which people a bit more resource poor than we are, at least for the moment, at NICE, would be able to do something.
Again, Clara Brunhuber from the BMJ Evidence Center. I can see one other opportunity or challenge here as well as part of guideline development, and especially the evidence work, to identify knowledge gaps and to utilize those in order to then trigger new research. Any comments from you on that?
I mean, it's clearly a major feature of systematic reviews, and one I think that a lot of us would argue that we don't fulfil as well as we would like to. We have long debates in Cochrane about empty reviews, but actually empty reviews that lead to research are really a very positive outcome. So, but that requires a level of attention to the task in terms of structuring those implications beyond something that's completely bland and unmeaningful. And it goes back to your paper and Polly and Brown and Ian's paper many years ago now about how to make those sections more useful.
I agree entirely, and it's one of the points I've got for one of the further questions, actually. But I think the gaps that we find in guidelines, I think we would be much happier if they went on to elicit research, and we do feed into the Duets database, but I guess then we don't know what happens after that, and that there's no feedback mechanism to then use the evidence when it's generated.
I have one question before we move on, and it's a follow-up to what David Tovey was saying, which in some ways the Cochrane collaboration is one of the solutions. It's a collaboration, and it's an effort to reduce unnecessary duplication for reviews. And I'd be interested in hearing from any or all of you or others about how to improve the way in which Cochrane fills that role. In other words, sometimes for good reasons, sometimes maybe for less good reasons, guideline developers and health technology assessment agencies do their own reviews. And so there's not collaboration. And maybe that's just the way it should be, but I'd be interested in, are there ways that sort of collaboration could be improved, particularly since that's often the biggest chunk of work when you're developing guidelines? Yeah.
I think this is going back to the fact that we're a small organisation and we've relied heavily on Cochrane reviews as our starting point to answer our questions. And recently, Robin's been doing quite a lot of work to get us more involved with particular Cochrane groups so that we can share our information and say, well, we're going to update this, when are you updating that, to just try and work together much closer so that we're avoiding the duplication and just using the best help that we can.
Just to add to that, I mean, we have historically, just as you were saying, Andy, not used Cochrane as much as we should have done. I think we have started to do so more recently, and I think Phil Alderson's currently working in sense between NICE and Cochrane to do that. Why we haven't done it in the past, I think, apart from thinking we could do it better, which is not a particularly good reason, but I think that probably did influence things, if I'm honest, is because it didn't quite address the question that the guideline group wanted answered. And the unpicking, and when we started early on to try and just tweak it, we found we were redoing it, and it became time inefficient. What we've done more recently, not just with Cochrane, but with a couple of other guidelines, is actually worked with the review developer, and very nice collaboration recently with the people at the Catholic University of Leuven, where they redid a very sophisticated small N study review for us in learning disabilities that we simply would not have been able to do. That's enormously helpful. But the collaboration was a bit about how they did the analysis. It was enormously helpful, and if we could do more of that. The difficulty, I guess, for David's colleagues is that they're giving their time free, and it's a challenge to kind of marry them up a bit, as Sonia was saying earlier on. But yeah.
Okay, we'll move on. I want to particularly thank Jaakko for coming with solutions and not just problems. And I'll encourage everybody to come with more solutions as we move along. So the next question is, what do clinicians and patients want from guidelines? And we've heard a little bit about that. Also from health technology assessment agencies and systematic reviews. And how can guidelines, health technology assessments, and systematic reviews be made more helpful to these different audiences? So, Jaakko, you want to go first?
A note before is that you do not have one physician or one patient for which you can develop a guideline in a format which is good, because there are so many differences. So there's no one size fits all. Doctors differ and patients differ. Particularly when doctors are confronted with guidelines within a program, produced within a program that just started, you see a lot of resistance, and so the process for acceptance, the phenomenon of guidelines takes time. We in the Netherlands have examples now, for instance, in dental care, that the dentists are starting guidelines, and there is a lot of resistance. You can't believe we are developing guidelines for more than 10, 20 years, but still there are groups starting it, and they go through the same process as we did 20 years ago. But every doctor is different. I see it when I look at young doctors in my practice. They like the apps, they like the internet. They don't use paper versions, but older doctors still want to print the versions. So I think we should not develop only one format, but different formats. And the same applies also for patients. Patients also differ. And that's the art of medicine, that you tailor your treatment and your management to each individual patient. And I think we should make flexible tools with the guidelines to fit all of them.
I think I'd have to be more honest and say that we don't actually know what healthcare professionals want from us. We produce something that we think they want. We produce a shorter version of it, and we do an electronic version. But I think that what we need to actually do, and is going a long way towards that, is actually just to do some research and to find out exactly what our healthcare professionals in Scotland really want from a guideline from us. And I think you can see the difference between the people who've come onto the group to develop a guideline. They want to produce something all-encompassing. They want it to be perfect. They want it to be extremely up-to-date. The best guideline ever. But then if you flip that round and you speak to the people who are going to use the guideline, they want something that's one side of A4, 5 recommendations. They want to be able to pick it up and use it instantly. So I think there's a lot that we could do to actually find out more what people, the users of the guideline, actually want. I think from the point of view of patients, I think there's very specific stuff that we've found anecdotally that patients want in terms of, I think they want reassurance that the guidelines are being used. And this goes back to the question of how well are guidelines implemented. We're not able to give patients reassurance that healthcare professionals are using the guidelines that we are producing. And I think patients want people to be accountable. They want to know that if someone is not using a guideline, there's a good reason why, and somebody's monitoring that. And I think that's something that we don't have a handle on at all. And in terms of patient information, I think we find that quite often patients want information about recommendations that have not been made in the guidelines, so they want some background. There are things that come up in the media or whatever. An example would be alternative therapies. I think people are always interested in things like that. It's not included in the guideline because we found no evidence. It's then not in the patient version but we're not saying why it's not in the patient version. So I think there's a bit of saying what's recommended, but also what's not recommended because of these other reasons, a bit of context. But I think my bottom line is we need to ask people more what they want from us.
I mean, Roberta's, I think, completely right that none of us know enough about what any of our users want in sort of detailed terms. I suppose when I think about patients, I go back to a talk I attended by Professor Per Fugeli, who's, I don't know what he is now, but he was then Professor of Social Medicine at Oslo. And he talked about trust, and it seems the closest I can get to this is as being a potential patient. You know, I want to be able to trust the person in front of me, and I want to be able to trust the system. And Professor Fugeli's piece was that the building blocks of trust were 5 things, of which 2 were shared power and realism. And it seems to me that in my job now, my responsibility is to make sure that people have the knowledge that allows them to make a realistic assessment of the effects of a treatment or a diagnostic test or another intervention, and therefore they can share the power, because I don't see how you can share power without knowledge. So I guess that's what patients need in terms of a sort of knowledge system, knowledge provider. People always say that doctors want something that they can read in about 17 milliseconds, and I'm not sure that I completely agree with that. I think if you want to know the dose of amoxicillin, you probably want to know that in about 17 milliseconds. But I had some time off in 1999, also a big year that year for me, obviously, when I went on a sabbatical and was looking at doctors' learning needs. And it seemed to me that all doctors had some questions that came up in consultations that they found some way to go away and squirrel away and read, and they might ring a consultant. Well, that takes a bit more than 17 milliseconds in England anyway. Or they might go and look it up. And so these weren't everyday questions necessarily. They were maybe 2 or 3 times a week questions, and that probably is where Cochrane reviews would fit into the sort of knowledge needs, I think. But clearly there are limits, and people don't want to have to read a 350-page document either. So I think there's something around conciseness, brevity. Clearly it should be relevant, should be accessible, understandable, digestible. It should tell you what it means, and it should therefore be actionable. Of course, reviews should stop short of providing a recommendation. I guess the other thing, just to finish, would be I think one of the things is about finding the balance between being authoritarian, and evidence can sometimes be perceived as being really authoritarian, and being facilitative. And I think both from the health professional and the patient's point of view, evidence that helps you to make a decision by telling you of your options is better than evidence that tells you that you should make this decision or that decision every time, because, as you say, there are frequent exceptions.
Right, I'm going to dodge this one by claiming that, well, I've been both a clinician and a patient during my lifetime. What I'd want, looking at it from both sides of the fence, is a couple of things I think we're not far off having, which is I think guidelines and guidance should help to create a dialogue and develop an informed and collaborative approach between clinician and patient. If they could do that, I'd be very happy, and that they want to do that on the basis of honest and accessible information that deals not only with absolute benefits but also with the harms associated with treatment. I think a lot of the tools we've been looking at the last couple of days do that, so I think we've already got some solutions there, or emerging solutions. But other things I think that people want is they want timely and up-to-date guidance. And if we're going to have that, it's not just about the methods of updating, but it's about the methods of monitoring. And we have systems like that at NICE, and they're really rather clunky and take time themselves, so almost work against what we'd want to achieve. But I think a simple solution for this might be for a guideline development group at the end of that process to signal where they think the areas of vulnerability are. What are the things that we think most likely need updating? And we highlight those, and then that already puts an alert into the system. And of course, the other issue that's been talked about at this conference, but is very much a preoccupation at NICE, is the business of comorbidity or multiple morbidities. And dealing with individuals' healthcare needs in that context is important, and we've talked about it, but it seems to me it presents a bit of a challenge for us, and one that, again, with NICE taking on issues around social care, has begun to address. It's very difficult often for many health problems, but certainly for people with multiple morbidities, to see those problems in isolation, see the narrow healthcare problems in isolation from wider personal and social care issues. I think if we're going to get credibility, particularly with some of David's former colleagues in primary care, I think the context in which we set some of our recommendations and taking into account that wider personal and social care issue is going to be important.
Thank you. Questions, comments?
Paul Garner from Liverpool. I think the idea of, in areas where patients have discretion to make choices, making sure the guidelines contain information that is useful to them to make those choices is something I've learned from this meeting. So that, for example, with malaria chemoprophylaxis for travellers, we've just reviewed 6 guidelines by different developed countries, and all the Canadian guidelines was the only one that mentioned the adverse, gave an estimate of the incidence of those effects. And yet that is clearly, you just have to pick up the newspaper, and the side effects of mefloquine is what concerns most patients. And so I think we do need to orientate ourselves to what the information that people want and need in order to inform their decisions.
Hi, Sean Trebeek again. Within the DECIDE project, we have worked with many patients, and something which I think is important for everybody to hear, some people have heard it already in the workshops, is that the work we have done talking to members of the public and patients about guidelines to a first approximation. Once we move away from groups of people like this, people have no idea that guidelines exist. And when I say that, I'm not talking about they don't know about the content. It's that they do not know that the concept of something that is a guideline exists at all. So that was an eye-opener for me. So I think we can't assume that people think that a guideline is the place to go to learn about what might be useful for my treatment decision. So it's upon us, therefore, to make sure that guidelines get into the hands of patients and the public, because they're not looking for it right now, because they don't know those things exist. Sure, I can see David's.
Well, I guess I'm sure that that's true, but I have sort of 2 sort of stories, really. Obviously, I try to get her in every time to this. And, when I said I was changing jobs from being a GP to working in evidence, when she got over the shock about the salary drop, she said, well, what is evidence-based medicine? And I said, well, it's doctors using the evidence to make their decisions. And she said, well, surely that's what they do, isn't it? And I found that a response from a lot of people. They just assume that was what all doctors have always done and were always doing. And, I always remember the story of the Isabel diagnostic device. 2 parents of a child who went to the hospital in London, was serially misdiagnosed for a very, very rare complication of chickenpox, nearly died, didn't die, and instead of suing the hospital, they noted that in their usually 3 o'clock in the morning interactions that very exposed doctors they were seeing had no information, access to the sort of information that they, working in the financial sector, would just regard as, like sort of putting a shirt on in the morning. So I think that probably the public just assume that's what's always happened, and that this is this is the essential framework that clinical practice is conducted in. And the shock is when they find it isn't.
I think the ultimate goal is not to be aware of a guideline, but be aware of useful, independent information. So for patients, they need to find a website with independent information. And we in the Netherlands have launched a website two years ago. It's thuisarts.nl. Thuisarts is home doctor. Yeah, home doctor. And all the general practitioners were told about the guideline. They got a blog with a prescription of the name of the website. So now we see 30,000 hits a day by patients who went to the doctor, and it can be shown during consultation, it can be shown visited before and after consultation. And now it's the website with information for patients. And the information is based on our guidelines, evidence-based guidelines. So if you type in Dutch, sore throat, then it's the first hit is thuisarts.nl. So you might consider to make such a website for patients.
I have one question that is from the perspective of clinicians. It may be a bit provocative, I don't know, but most people are probably familiar with UpToDate, and there are other commercial resources like that, where that's an example of a resource that is, my impression is many clinicians have found it very useful. They have managed to keep it up to date. My impression is they started out focusing on what clinicians wanted and then sort of worked backwards to build the evidence in. So they had less focus on the evidence to begin with than they do now. And my question is, what are the implications of that for you as guideline developers or systematic review producers, either in terms of are they your competitors, or are there ways that we can learn from what they've done and build that into national guideline programs? How do you view the different commercial producers like that?
These are the kind of things that we've spoken about quite a lot, and we tend to speak about things like that and maybe not really do anything about it because it becomes too difficult to say, well, how can we use that information? And then we say, oh, well, let's not bother, let's do our own thing. But I think it's another one of these places where we're using resource duplicating effort.
I think certainly my own view of it, and I think a significant view within NICE, is that such organisations collaborators to support dissemination. The challenges are that sometimes they can make some shortcuts with what's in there, or they could have other external influences on them that actually alter what's. But they do it very well. I mean, my favourite anecdote about this is when the first NICE technology appraisal came out on the cholinesterase inhibitors for dementia. And those of you from the UK will know this. There is a pack of biscuits called NICE. And whoever it was, which pharma company, sent round a pack of biscuits to NICE, I think probably to every psychiatrist and GP in the country, and said, here's a packet of biscuits called NICE, and inside it you will find from NICE the review of the cholinesterase. And enjoy the biscuits while you read it. It's kind of clever, and they do that kind of thing far better than we do. So I think it's got to be productive collaboration if we can make it.
Yep.
Well, the problem is that the guidelines do not cover all the conditions you see. So if you try to do that, we in the primary care we have 78% covered. So you do not need much other sources. But if you have a condition you cannot find any materials, you need other sources. And well, in my perspective, you have the next source would be the NICE or the SIGN guidelines or clinical evidence. But it does not depend on which source you use, unless you use still critical appraisal, so that you are aware of how the evidence has been found and that you are also sensitive for the context where it is produced. And my concern is, if I hear students talking about UpToDate, also in our country they are trained within the hospital with UpToDate, that they fully rely on that. So then I think we need to train them to still be critical.
I mean, sometimes I go a whole day and nobody mentions UpToDate. I mean, from our point of view, probably uniquely on this panel, we are trying into libraries whose budget's just been whapped out, paying for up-to-date. So that's not really a technical expression. And so although I don't think in any shape or form Cochrane Library is a competitor in content terms for up-to-date, we do very different things. They do with theirs very, very well. I hope we do ours quite well. You know, in real financial hard-edge terms, they're a real competition for us. And you know, I think you have to admire what they've achieved. They've been around a long time. They create an extremely warm. They're very, you know, the thing that always strikes me about Up-to-Date is, you know, when you read it, you know they're on your side. You know, it's the most sort of comforting read. You know, we suggest you do this. You know, honestly, doctor, you'll be fine. Just take our advice. And you know, I think that probably we all have something to learn from that. There are other elements probably we don't have too much to learn from, but that's certainly one thing I think is good on their part.
Okay, we're moving on to the next question. So now we're moving to policymakers. What is it that policymakers want? So these are people who are making decisions on behalf of a population, whether they're managers or senior policymakers, people in public health. What do they want from guidelines, from health technology assessment agencies and systematic reviews? And how can guidelines, health technology assessments, and systematic reviews be made more helpful for them? So, do you want to go first this time?
I think this is quite a difficult question because when we're developing guidelines, we are targeting healthcare professionals, I think, mainly. And we don't do anything specific for policymakers or managers. But I think after hearing a lot of the discussion that's been going on these last few days, that I think there's more we could do. My view of what they would want would be something that's more clear-cut than maybe we sometimes make in a recommendation. I think they want an idea of to take on something or to not take it on. And we've heard these past few days that that's quite difficult to do based on sometimes the evidence that we have and other factors that we need to take into account. I think that they will probably want something very brief and very targeted. I don't imagine that they'll really want the systematic review behind it. I think they just want to know. I also think that they probably want to see comparisons across the alternatives. If we have 5 options, 5 treatments for a particular condition, they don't want to know, right, here are 5 options. What they will want to know is, well, this is your first option, this is your second option. And I think on the back of that, they will also always want a clue to how much it's going to cost. And hand in hand with that, they want to know about disinvestment. They want to know what they can stop funding to fund the new things that you're recommending. Well, that's my view on it. I don't know if there are any policymakers in the audience who would want to look at a signed guideline. I'd be really happy to hear what they would want from us.
David?
Well, we've talked to policymakers a little bit over the last few years, and particularly in 2012, we interviewed about 20 policymakers, and what came across from those interviews very strongly was the things that they appreciated were independence and freedom from conflict. And, you know, we could debate that, but that's what they wanted. They actually liked about Cochrane that we were international, and so in this case they were paying for a little bit of it, but they were getting the benefits of the whole thing. The course wanted the reviews to be credible and believable, high quality. And I mean, in contrast to my last answer, they really all wanted the answers to be brief and really concise, and preferably at least one version one version that was about a sentence long. But also other slightly longer versions that their supporters could read and help to guide them. So, I mean, I think there's probably no surprise in any of that. I was really interested in watching the presentation this morning because when I was sitting in a WHO guideline panel about 2-3 years ago, I remember around the second day somebody said, well, the thing is, I'm a policymaker, I work for a policymaker, and he's told me to tell you that he doesn't want any weak recommendations, because weak recommendations are completely hopeless, and it just means don't do it. And so we sort of sat there with our mouths open for quite a long time, wondering what on earth we were supposed to say about this rather shoddy evidence that we were about to give a strong recommendation for or nothing. Anyway, I note that the world has moved on since those days, and I think that the way that it's moved on in terms of the framework that we were seeing this morning and other frameworks is much more useful, and I think that would have been a much better way of addressing that person's concerns.
Steve?
Well, we covered some of this. I think, and this is maybe one of the issues that's a little bit different in NICE. And I think policymakers want to know about population-wide benefit. And in my experience, they're much more interested in cost than cost-effectiveness. And that is about the shift and marginal shift in cost. Now, what NICE has done, and this may be a sharing issue, is develop a number of costing and implementation tools in order to try and inform commissioners and policymakers better of that. And maybe, as Sonia was setting, ought to be more sharing of that. But I think the other thing that, another thing that they want are not just ideas about what makes for a good treatment, but what are the systems that support effective delivery of those treatments, and what are the costs and consequences of the changes in service systems that would arise from that. And that is, I think, important. In the mental health field, we've spent a lot of time in our guidelines building in recommendations like that. But it's also, I think, worth noting that it, along with other recommendations which they're interested in, which kind of shape health professional behaviour, even shape patient behaviour perhaps, that as David was hinting at there, and we've noted throughout the conference, the evidence gets thinner, and it does present sometimes, I think, a bit of a threat. Organisations like NICE survive on their reputation and the fact that they're seen producing high-quality, strongly evidence-based recommendations. Some people may know NICE is now producing guidance post-Francis on safe staffing. And there's been some discussion whether setting what actually a safe staffing on an acute medical ward might be is something NICE should be in the business of. And what kind of threat does that present to organisations when we find ourselves going down the route which policymakers might want us to?
I think policymakers are directly not interested in guidelines. I mean directly. They in our country they think guidelines is to the field of healthcare professionals in collaboration with patient organizations. But they are not really interested in guidelines, but they are interested in whether the guidelines are followed and interested in monitoring the guidelines. So they are more interested in the indicators used to follow, used to monitor the use of guidelines than in the guidelines themselves. So that's one point. The other is and that's a good point, I think. Policymakers are very interested in the patient perspective because that's they vote on the political parties and they have links with political parties. So the patient perspective is very important. So they promote to involve them, and that will help also raise the quality of the guidelines. And they also raise the awareness of costs. And it took maybe 10 or 15 years until costs were accepted as being part of the considerations within guidelines in the Netherlands. But now all the guidelines developed in our country includes consideration of cost or cost effectiveness or even a budget impact analysis. And that's how you see the influence of policymakers and other parties and health insurance companies within the guidelines.
Do we have any policymakers or managers here? I know we had at least a couple.
Maybe not in my present position, now taking policies, just giving myself in my project, but I was policymaker in primary care in Norway for many years. And I think we need timely advice, maybe not timely guidance, not always guidelines, but we need advice, and we need it when we need it. If there is an outbreak of a disease, for instance, with an infectious disease, that's very important. And I think also we need explicit communication about uncertainties, about the guidance we are given. I think it's possible to communicate uncertainties to policymakers, but they have to be done explicitly. And it's not always that they just want, I think, the very strong recommendations, but they need help to express those uncertainties that always will be there.
Hello, I'm very definitely not a policymaker. I'm a guideline developer from SIGN. But I just wanted to comment, rather than ask a question, about the workshop attended this morning run by Roberto and Marina from the Italian team, who are using the Decide tool to try and adapt the Decide tool for use as a disinvestment decision-making tool. And I found that extremely interesting, because the one thing you need more than anything in a disinvestment decision, I mean, that can be made by all sorts of policy processes, but you almost need, even more importantly than guideline recommendations, you need a rationale to explain how that decision has been arrived at. And I think the Decide tool was particularly good at that, in breaking down the various different criteria that were important for deciding on disinvestment. I think we identified there were a few gaps, not surprisingly, given that the tool wasn't designed for that purpose, such as a description of how the disinvestment might be rolled out at the end of the day, whether it was a complete withdrawal or a phased replacement, and some descriptions of actually the implications of the alternatives when introduced, and some idea of the balance of costs and potential harms as well. But I think as a starting point, it seemed like a really useful potential adaptation of the Decide tool. So I'd be really interested to see how that follows up.
Okay. Last question. This one is focusing on researchers and research funders and publishers. So I don't think we have any funders here. We do have a number of researchers and publishers. What do guideline developers, health technology agencies, and producers of systematic reviews need from researchers, research funders, publishers, and each other that can facilitate improvements in the quality and relevance of guidelines, technology assessments, and systematic reviews? So, David, it's your turn to go first.
Okay, so I guess different things from each of those. If we think about researchers, the very obvious but nonetheless necessary thing for me to say is that we need your data. We need data from whether you publish your trials or not, the data needs to be available, and all the data from those trials. So that's one thing we need. I think we need, I would really strongly encourage researchers to look at using things like core outcome sets. Should use core outcome sets much more, but obviously that's somewhat dependent on the primary research using them. And, I think we would really like researchers to start to see systematic reviews as being a sort of central part of a research strategy. They're not the sort of bolt-on at the end. You do the primary research and someone comes along later and does a systematic review. The systematic review should be informing the development of clinical research by identifying uncertainties and indeed research that would be wasteful. So I think about funders. I think in general we're very lucky to have a good level of interaction with funders, and that honest about what they want and being realistic about how that can be achieved, and that's in terms of the content, the quality, the scope, and all those things. And I think my answer to this and also the next bit about guideline providers is the same. Essentially, what for Cochrane and probably other systematic review producers, what we need is a really good engagement with both funders and other and large level users like guideline bodies, in order to understand how to make the product, the thing that we do, more effective and useful. And I guess going back to question one, the follow-up of question one about why do people who are guideline bodies not use Cochrane reviews or other people's systematic reviews? I think there's, in an ideal world, I'd be able to change other people, but actually in practice we can only change ourselves. So, I think it's behoved Cochrane and us as a systematic review producer to get out and find out why it is that people are not using our reviews and what the problems are, and how can we make that gap between what we produce and what you need somewhat shorter than it is now. And we can't just sit there expecting you to change. We have to engage with you and understand more about what the issues are.
I'll start with a kind of very parochial, not parochial, but a very particular local point. I mean, there are some populations which are significantly and seriously under-researched. So, for example, in my world, about 75% of mental disorders start in childhood or adolescence. Less than 10% of the research that we look at is on child and young and adolescent mental disorders. We need a fundamental shift in the focus of research in mental health. And that not just applies to children, but to other excluded groups, people with learning disabilities, neurodevelopmental disorders, people whose lives are blighted, but whose care is also pretty much blighted, really, because we don't really know what's effective. So I think there's a real need to shift the focus, certainly in mental health, and I'm sure others here working in other areas would say the same about their world. I also think that as we move into a world of more complex interventions, we need more data, as David was saying, on the effectiveness of complex interventions. And as repeating a point I made earlier, the interface care and how we provide and make recommendations about effective recommendations in this area seems to me also important. And just a couple of final points. Quite a lot that's been very encouraging about clinical decision-making tools, and as I said, NICE has a preoccupation at the moment with multiple morbidities. The solution, I think, there is not going to be develop a massive suite of guidance where we have per, one disease from 5 and how it might combine with the other 3 to produce various bits of guidance. But I think we're going to have to be looking at developing tools, which I think is a research task, that you can begin to look at not just is it warfarin or aspirin for atrial fibrillation, but what about the person who has COPD, diabetes, and something else going on? How do you bring together the existing guidance? I think is a real serious research challenge. And then there's a final research one for me, which is what do we know about actually how we write guidelines, recommendations, how we build implementation tools that actually do make a difference? I think that's a really under-researched area, and I think we need to be starting to work with people in the implementation science, quality improvement world and think, can we craft things differently? They've got ideas about how you bring about behavioural change for health professionals. Shouldn't we be bringing that into the way in which we start to write some of the guidance that we're producing?
I distinguish 3 fields of research. That's the development part, implementation and evaluation. And in the development field, well, the DECIDE project, a lot of tools were developed, and I would be very interested in whether it really works in practice and what's needed to let it work. And you could distinguish then the beginning developer and the advanced developer and try to do some training or other strategies to implement. I think it needs more testing to really make it work, and I'm much looking forward to that. Another part is the implementation. We need to know what the determinants are of effective guidelines. There has been done a lot of studies about it, but I think it can still be continued. And I think the outcome is not only that some people are interested in patient outcome, but a lot of other factors are also influencing that. You could focus on the process, but also on the satisfaction by the healthcare provider and the patient. So how they use guidelines, how they use decision aids derived from the guidelines or presented within the guidelines, how they perceive that. That's more qualitative process. I could imagine even videos of consultations between doctors and patients, how they use guidelines and decision aids. And it does not depend on the outcome, but how they do that and whether they perceive it helpful. So that's, I think, an important point. And the final is the evaluation field. We know a lot about the development. We know a lot about implementation, but we still do not know much about the use of guidelines and whether it really affects healthcare. So there should be a monitoring system where you can systematically follow, study the implementation and the use of guidelines, using indicators on an aggregate level, on an individual level, on a practice level, and we are now starting up the system, and that's increasingly important also for the guideline developer, because then you get feedback of the use of the guidelines, and you can maybe adapt or modify the recommendations.
Roberta?
I think I find that I've not got much left to add to those really extensive answers to the questions, but I think I will just reiterate. Obviously, the main thing that we want to do when we're developing a guideline is answer the questions that the healthcare professionals, the guideline development group feel that are pertinent in that particular situation and setting. So I would just say what we need is, from the trials, we need realistic comparisons in the trials. So actual interventions that would be sensible interventions that people would have a choice between. Realistic populations, we heard a couple of days ago about the patient population not matching the population in the trial, and the efforts that you have to go to explain how you're extrapolating that. So realistic comparisons, realistic populations, making sure that harms quality of life, and I think from the session that I was in earlier, some indication of what the people in the trial, the patients in the trial, their values and preferences, how they felt about the treatment rather than just how they reacted to the treatment in a physical way. And to bring all of that together so that we can have meta-analysis, so we can have systematic reviews, people using validated tools, and the outcomes as well, so that we have a consistency and we can make stronger recommendations because we can pool the results. I think just to finish off, though, I'm going back again to reiterate what Sonia said about working together, and I think when we're coming from a position of being small organisations, I think the business of working together with your colleagues in your close neighbours or colleagues in Europe is really important for all sorts of resource issues, and to standardise what's happening and to push these ideas about publishing negative results and making sure that the trials reflect your patient populations. I think as a collaborative we're able to push that better than small organisations together.
I think I've been producing systematic reviews for about 20 years, and the technologies and the tools to use those reviews in policy have advanced so dramatically, and this conference really shows that. But the biggest issue, I think, that we as guideline developers really need to tackle is things to do with competing interests and managing competing interests and expressing them. And usually it's separated from the guideline process, or the ones I've been with, so long as there are. But always people have. And, you know, we've people with large Gates research grants in the topic that's being discussed by the guideline panel. In some guidelines panels, the $20 million is not seen as likely to influence the chair's view on the intervention. And we've really got to get to grips with this and get it open and discussed. It's not just about commercial competing interests, it's about academic competing. If this is an area of research that you want to push forward and you've got a lot of ownership of, and I don't believe the academics on the panels think that they're doing wrong, but they just know that they're right, and they might not be.
Does anybody want to respond to that while we're waiting? Yeah.
Just a very quick response. I think that it's obviously something we've been wrestling with for a long time, and deciding how to deal with declarations and whether there are conflicts of interest. I know I'm coming back to this again and again, but being a small organisation in a small country, if you're doing a guideline on a very specific topic, that maybe you've got the whole pool of specialists in the country on that guideline topic, and it's then very difficult to develop that guideline without having those people around the table.
We have struggled with this very issue, and I don't think there's probably very few people, perhaps the patient members, probably the people in our guidelines who have absolutely no interest. And we have toyed quite seriously with the idea that we would have a complete group of generalists who knew absolutely nothing about the topic. And I'd be anxious if we did that, really, that I think there is something about special knowledge and expertise that makes a guideline development group better. But we try to be transparent. We exclude people from discussions where we think there may be a conflict of interest, and we have on occasions excluded people full stop when conflicts have emerged. But you're right, it's a problem.
It's also about managing it as well.
Yeah.
You know, it's not necessarily about excluding them, but it's about making it explicit.
Yeah, well, that we do.
Adding to the conflicts of interest, I also want to mention circular reasoning in research publications, which extends conclusions to much too many patients often, and real conflicts in and discussions in which patients often are a minority in number in the group that decides. So at the end, patients will be outvoted by specialists with much more interests in other things.
Okay.
So one quick comment on the conflict of interest, and then a question for Jaco. So the comment is, in some of the testing of the ETDs, the issue of labeling conflicts during that process has come up, and I think we've ignored it. There may be good reasons for that when it's appropriately managed, but conflicts can play various roles during the different steps in the evidence to decision framework development. And once again, it came up at least once, something that needs to be noted, I think, in one user testing, a rare disease guideline. Jaco, I have a comment for you. You said further testing is required, or further testing is required of the products that are resulting from this work, which is pretty obvious. But my question to you is, what is the reference standard, right? The reason for why these tools are being developed is because there are no good tools. And where do you start evaluating? In fact, I don't believe in much of the implementation literature around guidelines, because what has been included in many of the systematic reviews that look at the implementation literature are pretty badly done guidelines, and that adds a lot of noise. That's the first thing. But anyway, what's the reference standard? And perhaps I should give you a chance to answer that.
I think that's a good question. I think the process as usual, well, that's the starting point. And you want to also raise the quality of the guidelines, but you may assume, if you talk about advanced guideline developers, that the guidelines are okay. So you can also test that, but I'm primarily interested in whether the guideline developers think it really helps them, and it's not bothering them because of lots of administration or lots of website pages and clicks, and so that's what I want to know, and I hope it can improve the tool by making it more simple. That's what I would like to know.
But what if these methods that are currently existing, and I'm specifically referring to smaller guideline developers, are simply not good methods? There is no sense in using them as a reference standard, but producing a new reference standard. And that relates to something that was said earlier around small guideline developers. How can they use these tools? I mean, if you look at what is happening both with the GIN standards and with the IOM standards that I continue to believe are at least helpful, these small guideline developers probably have very little role in the guideline development because they cannot do systematic reviews, but producing guidelines without systematic reviews makes no sense.
Yeah, I agree with that, Holger. So I think we should begin with the more advanced guideline developer, and even then, I think they need training. Like the great approach, it needs training, and now you see people are familiar with that, they are adopting it, but it needs time. But you need to know what are the problems in practice when they use the tools, and start with advanced guideline developers, and then you can spread out it to the whole world.
So we're going to wrap up. Sean, you'll get the last question, and I'll give each of our panel members a chance to make any closing remarks they want to.
I'll make this a bit shorter than I had intended then. I just wanted to pick up a point that Stephen made and a Dutch colleague over here to do with what do guideline producers want from research. And as somebody who designs trials, I think what guideline producers and many others want from researchers are, if you're thinking of trials that are actually useful. And my sense is that many of the trials that are being done now are rubbish. And they produce results which are not helpful in answering very important questions. And to pick up a theme of Sonia's, we almost want a dating agency that puts important problems in touch with researchers who have a rigorous approach to answering those questions, which will then be relevant to people such as guideline producers. So I think there's an awful lot of people doing trials which produce results that are of very limited use beyond their own interest in an area. And that is a fundamental problem, not only for guideline producers, but for all of us.
A quick response to that is, as you will know, at the end of the guidance that NICE produces, there are a series of research recommendations. Now, our personal experience, I'm talking of the mental health field there, is relatively few of those questions are taken up. I don't know if there's anybody else here from NICE who could give an overview of where the rest of them are. Maybe we're just rubbish at writing research recommendations. That could be the answer. But I think not. I think the difficulty is that the kind of questions that we often pose don't, if I'm being a little cynical about it, don't quite fit with what is the kind of current zeitgeist or current methodological penchant of people running the big funding groups. We might want a 3-arm trial, we don't want a 3-arm trial. It is quite tricky to actually persuade people, and I can think of probably in 12 years something, and that would amount to 30, 80, probably about 200 research recommendations we've generated. I can think of 3 that have been taken up. It's a problem.
Yes, I mean, I suppose I would agree with you. I mean, I guess we need to look at what that rubbish includes, and it includes studies that replicate studies that have already been done, attempt to answer questions that have already been answered. It's difficult to know whether that's voluntary or involuntary, and it involves people knowingly doing studies that they have a interest in the answer of, and therefore setting the study up to balance one way or the other. And I guess there are probably studies that are just set up so badly that they can't deliver a meaningful answer. You're absolutely right. Certainly from my perspective, what we need are trials that answer really important questions, that look at harms, that look at outcome sets that are validated and meaningful to the decision makers, and as you say, we see too little of that.
Do you want to say anything else?
Not specifically about Sean's point, but I think just to wrap up, I think for the future, what I want to see for our organisation, for SIGN, is I want to find out what it is we actually need to produce for our guideline users, so that we can focus what we're doing on what it is they actually need. So I think doing some background work, taking what we can from Decide, and then really finding out what they want, whether if, as we imagine, people want a comprehensive guideline that goes from A to Z, or whether it's something different that they want, so we can focus all our resources on just exactly what the users need.
Anything else you want to?
It's not about this. It's about a promotional thing. In August, we have the Gin Conference 2013 in Melbourne. It's in Australia. It's far away, and I know some people of you are going to there. And those who are not going to Melbourne, next year, in 2015, we have a conference in Amsterdam. I'm very glad and happy that I'm chairing the organizing committee. The chair of the scientific committee will be Jos Kleine. You know him from the systematic reviews. He's the chair. So I would welcome you in 2015, 7 to 10 October. That's from Wednesday to Saturday, 2015 in Amsterdam.
I realised that I'd failed the obvious setup that you'd made for me to mention that one of my tasks in the next 9 months is to come up with a list of the 200 most important high-priority reviews that need to be conducted or updated within Cochrane. People in this room who can help me out with that. And so I shall leave my card somewhere very prominent like here. And if you want to email me with a list or inviting a discussion, I would be enormously grateful.
Great. So I'd like to, before I hand over to Robin, first thank the panel. You're brilliant. Thank you very much. And before I hand over to Robin, I want to thank Sean and particularly Robin and his team here for putting on a wonderful conference. You mistakenly gave me credit. Thank you, but I don't deserve the credit. And some of you may know Robin thinks he's retiring, but we'll just let him think that. Robin, thank you.
Thanks, Andy. Well, congratulations on surviving the last 3 days of very intense discussions. As somebody mentioned the other day, this conference was originally supposed to happen next year, but we thought, well, it might be better to give ourselves a bit of time to cope with any feedback that we get in the course of the conference. And as it turned out, that was a very good decision because we've had a lot of feedback over the past 2 or 3 days, a lot of very useful feedback, and thank you very much all for contributing to that. I think the obvious question is, where do we go from here and what happens next? Well, I think various working groups are going to go back and consider what they heard in the past 3 days and see what they need to do to adapt and improve on the work they've already done. And then report that out at future meetings, like there will be sessions about DECIDE at the GIN conference in Melbourne later this year. There may well be this year. And there will probably be something about DECIDE at the GIN conference in Amsterdam next year, hopefully. But just before we go, I would just like to add to Andy's thanks to Leslie Forsyth and Gemma and Gaynor make this conference work, and also the college officers who've worked at IT stuff. I think for once I'm not aware of any occasion when IT didn't work as advertised, which is extremely unusual. So I'll say a vote of thanks to them who really made this work. And the one other group of people we should really say thanks to are the people who work on the various DECIDE working groups for getting DECIDE as far as it's come and for all the work they put into preparing the workshops and whatnot the last few days. So thanks very much to them. And I think that's it. So thank you all for coming and have a safe trip home.